and welcome to this another session of the TIRO MDS. Every week we bring in some of the most celebrated leaders in the field of thyroid surgery, endocrinology, and pathology. These sessions have been extremely educational, highly educational, and they are all on the Google. You can read them or look at them anytime. There are more than 250 sessions, and this is a great fund of knowledge for those who are interested in endocrine surgery and thyroid surgery. Today, we are especially proud of having two most outstanding pathologists present us one of the most controversial subjects in thyroid surgery. What do we do about the large tumors when they turn out to be malignant pathology? And I think this is a very interesting subject. The ATA guidelines have elaborated on that. And we are very fortunate this morning to have a presenter, Dr. Bin Xu. Dr. Xu is a senior endocrine pathologist at Memorial, working with the best group of people who have revolutionized the pathological approach to thyroid surgery. And her presentation will be quite intriguing. She was trained in McGill and has been in Memorial for more than 10 years as a pathologist. And I work very closely with her. One of the best advantages of working in a tertiary care center is working with the people who are outstanding and, more importantly, easy to reach, easy to talk to, and easy to discuss. Our discussion this morning is none other than Dr. Margaret Brandwein-Weber. She is truly who is who in the head and neck and endocrine pathology. Her presentations are outstanding, and her contribution is well known to every thyroidologist around the world. Welcome, Margie. Welcome, Bin. And we'll start with Bin's presentation.
Okay, thank you for the invitation. And thank you, Dr. Shaha, for such a nice introduction. So today I'm going to discuss our paper that was published last year in Thyroid, entitled Large, more than 4 centimeter intrathyroidal encapsulated well-differentiated follicular cell-derived carcinoma without vascular invasion may have negligible risk of recurrence even when treated with lobectomy alone. I have nothing to disclose. So the reason to get to the paper first, we have to discuss why we want to study this this particular tumor subtype. The reason is that the tumor more than 4 centimeters in size without gross extrathyroidal extension using the current AJCC8 edition will be classified as PT3A. And according to the American Thyroid Association guideline, for this group of patients with thyroid cancer more than 4 centimeters in size, they should undergo a near total or total thyroidectomy, and the post-operative radioactive iodine therapy should be considered. Similarly, the NCCN guideline have a similar recommendation. They recommend it for tumor 4 centimeters in size with a preoperative diagnosis on fine needle aspiration as suspicious or PTC, Bethesda 5 or Bethesda 6, they should undergo total thyroidectomy. Furthermore, if a pathology diagnosis of well-differentiated thyroid carcinoma more than 4 centimeters in size in the initial lobectomy, the patient should be treated with a completion thyroidectomy, and post-operative REI is selectively recommended. There is a commentary right by the famous Dr. Rosai, a pathology giant, and with a special interest in thyroid pathology. He said that if a given tumor type was consistently diagnosed as malignant, but the tumor were to stubbornly fail to act in a malignant fashion, one should presume that that would cause for reflection and correction. This is particularly true for thyroid pathology, where many tumors have an indolent outcome. And such reflection and correction do occur in 2016, where Dr. Nikiforov and Dr. Doseng from UPMC and MSKCC have lead to this landmark study that renamed encapsulated follicular variants of papillary carcinoma as non-invasive follicular thyroid neoplasm with papillary-like nuclear feature, NIFP, to get rid of the carcinoma terminology for this group of patients. That the patient with a non-invasive encapsulated lesion of follicular pattern but showed PTC-like nuclei. Among that study, 109 patients was included. None of them received radioactive iodine. With a median follow-up of 13 years, there's no recurrence. And large NIFP, meaning a NIFP more than 4 centimeters in size, do occur. In a study published subsequently to the landmark paper of NIFP, from 4 tertiary center, we do find that a large unifocal NIFP, 4 centimeters in size or more, have no risk of nodal metastasis or recurrence, including those patients that was not treated with post-operative RAI, with a median follow-up of 5.8 years and up to 26 years. So with all these changes in the past decade, the new WHO classification that was published last year do classify follicular pattern lesion based on their invasive status into 2 big categories. Those are encapsulated and non-invasive. It's usually classified as benign and or pre-malignant. That would include follicular adenoma, oncocytic adenoma, and NIFP. Those with any degree of infiltration or invasion, including capsular invasion, will be termed as carcinoma. That would include follicular carcinoma, oncocytic carcinoma that was previously called Hurtle cell carcinoma, and follicular variants or follicular subtype of papillary carcinomas. Furthermore, this follicular pattern carcinoma can be further substratified into 3 categories. The minimally invasive are the one on the left. Those showed only capsular invasion, but without any angial invasion. And then there's angio-invasive tumors that show vascular invasion. And on the right are the widely invasive carcinoma that showed gross thyroid invasion in a multinodular fashions. Well, based on the literature and our experience, we know that angio-invasive and widely invasive follicular pattern carcinoma can have a risk of distant metastasis and disease-related mortalities. Experience tell us those with minimally invasive usually do nothing. And this was exactly quoted in Rosai's commentary. He mentioned that a good example that need reflection corrections are encapsulated well-differentiated thyroid neoplasm with a follicular pattern growth and showed capsular invasion only, but no vascular invasion. Well, every textbook and monograph on the subject, including his own, tell that such tumor should be a carcinoma. It should be called minimally invasive follicular carcinoma, yet personal experience and the review of literature will demonstrate that if the only sign of malignancy of a thyroid tumor is a capsular invasion, the chances are practically 100% that a conservative operation, usually in the form of a lobectomy alone, will be curative. And the literature does reflect such observations. Here, I'm just quickly quoting 3 papers. The first one from Mayo Clinic, published in 1992, where they studied 65 cases of follicular thyroid carcinoma, subgrouped into minimally invasive and angio-invasive group. And you can see that the minimally invasive means those tumors with capsular invasion alone have no risk of distant metastasis and disease-related mortality, while those with angio invasion have a 19% risk of distant metastasis and 28% risk of disease-related mortalities. Similarly, we have looked at encapsulated papillary carcinoma, follicular thyroid carcinoma, and oncocytic carcinoma in 2015. And when substratified based on the invasive status, once again, minimally invasive carcinoma, except the 3 patients have distant metastasis presentation, that would be classified as ATA high risk regardless, and 2 of them have a death of disease. All 3 tumors are encapsulated follicular papillary carcinoma. So in excluding these 3 patients with distant metastasis presentation, there's no risk of recurrence or disease-related deaths compared to the angio-invasive one that have 20% risk of distant metastasis and a low risk of disease-related mortalities and local regional recurrence. Lastly, 2 years ago, led by Dr. Kenny, I'm an MSK surgeon. They also studied follicular thyroid carcinoma and oncocytic thyroid carcinoma, and they found that under the minimally invasive group, meaning those with capsular invasion alone, the risk of distant metastasis and disease-related mortality only occur in 1 patient who have distant metastasis presentation. Otherwise, there's no recurrence, either regional or distant metastasis, and no disease-related deaths, compared to angio-invasive group that do have a risk of distant metastasis and disease-related mortality. So that's actually leads to our study. So because of the confliction of overall perceived indolent outcome in the group of patients with well-differentiated carcinoma with capsular invasion only without other risk factors and a high AJCC stage, as well as ATA and ACCN mandates for total thyroidectomy and consideration of RAI, we decide to focus on the large encapsulated well-differentiated carcinoma with capsular invasion only and look at their clinical outcome. So in our study, we include only patients with 4 centimeter or bigger thyroid carcinoma. And all tumors should be encapsulated with a diagnosis of papillary, follicular, or oncocytic carcinoma. We do allow additional sub-centimeter foci of papillary carcinomas. Exclusion criteria are basically those with higher, intermediate, or high risk, considered as an ATA guideline. That would include any degree of vascular invasion, any infiltrative tumor, any extrathyroid extension, either microscopically or grossly, positive resection margin, either microscopically or grossly. NIFP is excluded as it's already a pre-malignant lesion rather than carcinoma. And we also excluded high-grade follicular cell-derived carcinoma, which is defined by elevated mitotic index and or tumor necrosis, or aggressive subtype of papillary thyroid carcinoma, such as tall cell subtype. But for patients with less than 1 year follow-up, as we are looking at the outcome of the patient mostly in the study, we also excluded them. The primary outcome we are looking at nodal metastasis is the time of primary resection, as well as disease-specific survival and disease-free survival. Here is just a flow chart of our study design. So the pathology database actually allow us to search using keyword. So from more than 11,000 of thyroidectomy that we reviewed and received in pathology, using different keywords such as capsular invasion, vascular invasion, we identified 183 candidate cases fulfilling the initial inclusion criteria. All cases was reviewed clinically and pathologically to exclude other entities such as NIFPs, insufficient follow-up. There's one case with vascular invasion that was not reported, but was identified as upon pathology review. We also exclude 1 cases of distant metastasis presentation, 1 PTC tall cell subtype. That ended up as a study cohort of 88 patients. Among them, 32 patients was treated with lobectomy or hemithyroidectomy alone, while the other 56 was treated with total thyroidectomy. Here is the diagnosis of our study cohort. Notably, it's predominantly papillary thyroid carcinoma, and among papillary carcinoma is predominantly encapsulated follicular variants. We consider follicular pattern lesions is predominantly encapsulated follicular pattern carcinomas that we include encapsulated follicular variants, follicular carcinoma, and oncocytic carcinoma, accounting for a total of 64 patients or 72% of the study cohort. Go back. Other unusual subtypes are the encapsulated classic type of PTC and encapsulated solid subtype of papillary carcinoma, accounting for 20 cases and 4 cases in the study cohort. When we look at the basic clinical pathological features, just like other thyroid carcinoma, is commonly in female. Affecting mid-age patient with a median presentation of 52. By definition, the tumor have to be larger than 4 centimeters for the study, and the median tumor size is 5 centimeters. There are about 33% of patients have additional foci of sub-centimeter papillary carcinoma. Get to the issue of tumor sampling. In our study, about 68% of the tumors are either entirely sampled or have the tumor's capsule entirely sampled to evaluate for invasion, while the rest 32% is representatively sampled with a median number of tumor blocks of 10 sections per tumor. When comparing patient treated with lobectomy alone versus patient treated with total thyroidectomy, overall, the clinical pathological features are comparable between the two groups. The only difference is that the total thyroidectomy group have more frequency of additional foci of carcinoma, being 46% rather than 9%. And they have longer follow-up, being 5.4 years compared to 3.7 years in lobectomy alone group. Naturally, REI can only be given in the total thyroidectomy group, leading to a high frequency of total REI in this group. So we first look at the nodal metastasis in the primary resection. That only happened in 5 patients, or 6% of the total study cohort. As you can see here, the list of the 5 patients, all of them are the papillary thyroid carcinoma classic subtype. All patients underwent a total thyroidectomy, and 4 of the patients received additional postoperative radioactive iodine. At the end of the follow-up, ranging from 1.8 years to 16 years, there's no evidence of disease recurrence. The bottom line here is that classic papillary thyroid carcinoma, even when they appears encapsulated, they may have regional metastasis. That's just designated by the BRAF-like signature of a classic papillary thyroid carcinoma. The more important follow-up will be the follow-up and the survival. As mentioned previously, in our group, there are 32 patients, or 36%, was treated with lobectomy alone, and 62% of the patient, being 55 patients, did not receive post-operative radioactive iodine. With a median follow-up of 4.8 years, ranging from 1 year to 20.6 years, there's no evidence of recurrence or disease-related death, which translate to 100% disease-specific survival and recurrence-free survival in our cohort. Here is just a quick example of one of such case. It's a 54-year-old patient. You can see the tumor is 4.2 centimeters in size and have exclusively follicular pattern of growth, and point by the black arrow showing one focus of capsular invasion. And this patient was disease-free 11 years and 9 months after diagnosis, and the patient only underwent a lobectomy without RAI treatment. Now, before I get to the conclusion, I want to just quickly mention the potential weakness of the study. So first of all, it's a sampling for invasion. Although most tumor, being 68%, are extensively sampled with the capsule submitted entirely for invasion, there are 32% that was only representatively sampled. Next, I want to just mention the intrinsic weakness of pathologic examinations. So even when you see in the report that the entire tumor capsule is submitted for histologic examination, in realities, even we embedded all the tumor into paraffin block, we are cutting one section of 4 micron thick from a 3 millimeter thick block. So the actual sampling rate is about 1 in 750. So it's practically impossible to truly entirely examine the tumor capsule. Is there any alternative of other than HAE sections? We do try different methods to see whether we can evaluate angio invasion and capsular invasion in thyroid tumor using other technologies such as micro CT, which is basically a CT scan, a high resolution CT scan of a paraffin block. So we found that when serially scan into the block using the micro CT, we do find additional foci of capsular invasion as indicated by the black arrow and the blue arrow, compared to the H&E only shows 3 foci of capsular invasion. Micro CT were able to capture additional capsular invasions. However, the resolution of micro CT is not enough for more important pathology parameters such as angio invasion. So it appears that additional fancy technology may have added value, but it cannot replace HIE in thyroid pathology. Other weakness of the study is the study follow-up is relatively short for indolent tumors such as this. The median follow-up is only 4.8 years, ranging from 1 year to 20 years. It's also a single center study, so we have limited sample size of 88 patients, and it's retrospective in nature. However, there are larger international multi-center retrospective study coming, just like the design of NIFP. This is led by Dr. Nikiforov. They're studying, the study's patient selection is slightly different. The study follicular pattern lesion only, so they excluded all the classic PTCs. The tumor have to be entirely sampled to encounter the sampling issues. It include any size, so no longer focusing on 4 centimeter or more. And the follow-up have to be long, at least 5 years up to whatever the follow-up we can get. So the results of this international multi-center study is still coming, so stay tuned. So that leads to my conclusions. So basically, based on our data, we show that large, more than 4 centimeter in size, intrathyroidal, encapsulated, well-differentiated thyroid carcinoma without other risk factor is extremely indolent with negligible risk of recurrence or disease-related deaths, even when they're treated with lobectomy alone and without post-operative radioactive iodine ablation. The caveat, as we mentioned, is that the tumor requires extensive sampling to evaluate for invasion and also experience pathology to exclude other risk factors such as angio invasion. Taking everything together, we saw that consideration may be given in treatment guidelines such as ATA and NCCN guidelines to recommend lobectomy alone for this particular group of patients rather than total thyroidectomy with postoperative RAI. So that's basically my presentation. Thank you very much. I guess the questions by the end.
Yeah. Thank you very much, Dr. Shu. That was an outstanding presentation, summarized extremely well. And I'm very happy that you were able to bring up some controversial issues. This is the place where the surgeons, the endocrinologists, and the pathologists work hand in hand. We learned so much about the tumor pathology from you that we can make clinical decisions based on what you tell us. So your involvement in our patient care, even though you are in a different building, you are in a different area, you are the most important person to give us the guideline based on the pathology. So thank you very much for an excellent presentation, good study. And even though you have mentioned the short-term follow-up, this is pretty good follow-up to see these patients are doing well. We're also fortunate this morning to have, as I mentioned before, one of the most outstanding thyroid pathologists, Dr. Margaret Brandwein-Weber. She's a site chief of surgical pathology at Mount Sinai West. She also holds the position of president of the North American Head and Neck Pathology, which is clearly an outstanding achievement. She also runs the Head and Neck Pathology Fellowship at Mount Sinai. So Margie, welcome.
Thank you, Ashok. Your greeting is your intro is much too kind. So thank you, Bin. Next slide. Yeah, I want to extend my congratulations to you, Bin. It's a beautifully presented lecture that you just gave, and kudos to the entire thyroid pathology team at Memorial for consistently chipping away at the boundaries of our ignorance. Okay, next. So are we overtreating low risk, big tumors, big 4 centimeters or more? And as Dr. Zhu has told us, the current ATA guidelines recommend subtotal to total thyroidectomy and consideration for RAI for what is now PT3A disease. The inherent assumption is that there's an inherent aggressiveness which leads to the tumor being able to attain such a big size. And I bring up, what about substernal malignancies? You know, substernal tumors, because they remain silent for a long time, they tend to be bigger. But if they're bigger, does that mean that they're badder? So this is a great study to address these, everyday working problems. And I'll just say we had a case last week in tumor board in Mount Sinai Hospital tumor board, which was 10 centimeters, and it was substernal. And it didn't quite fit your restrictions because it did have, 3 vessels involved. So, I was able to say, well, this is a blind spot right now. Okay, next, please. Okay, so why do we need studies like this? Well, the older literature that Dr. Zhu referred to, there is older literature that demonstrates that a larger tumor size is an adverse feature. But these are invariably older publications, some of which don't even include pathology review. And certainly at the time of their publication, even if they had pathology review, there was a lack of awareness of the significance of necrosis and elevated mitotic activity. So today, these tumors would be reclassified, as not well-differentiated thyroid carcinomas, which is the group of interest here. So that's why we need these current studies. And also, this is the less is more era. In older studies, people were not looking at, well, what's the minimum amount of surgery that we can do to adequately treat the patient? So this is just one example of older literature that been referred to. This is a study with almost 4,000 patients, and the patients were classified as low risk by the 2012 criteria. And that means that they did not present with distant metastasis, there was no ETE, and there were no clinically positive lymph nodes. So the current concept of low risk is certainly very different than the concept of low risk over a decade ago. And here they divided tumors into 3 groups: less than 2 centimeters, 2 to 4 centimeters, and 4 and more centimeters. They were not able to find any differences between the 2 to 4 and more to 4, but the significant differences lie between the significant cut point was between 2 centimeters and more. And there, in this study, this was found to be an independent predictor of recurrence to local positive lymph nodes. Next, please. So here we are in our current, working map. So we see what is defined as low risk. So you have less than 4 centimeters intrathyroidal, no BRAF mutation, and then intrathyroidal between 2 to 4 is about 5%, which is probably the ceiling of low risk. And here in red is where we are in terms of like trying to approximate the group that BIN is addressing. If you have a PT3 with minor ETE, you have a risk of recurrence about 3 to 8%. So let's say 8% is the bottom of intermediate risk. And if you have intrathyroidal, again, less than 4 centimeters with BRAF mutated, you have a risk of about 10%. Okay, next. Next, please. So as we heard, we had this is a retrospective review of 88 patients of interest. And the inclusion criteria were well-differentiated thyroid cancers, more than 4 centimeters, intrathyroid encapsulated plus or minus capsular invasion. And this was, so the group of interest that was studied were encapsulated follicular variant PTCs, classic PTCs, solid PTCs, follicular carcinoma, and oncocytic or Hürthle cell carcinoma. As we've heard about the exclusionary diagnosis, the exclusionary criteria, NIFT-P, short follow-up, presentation with distant METs, and any vascular invasion, any tall cell invasion. And as we heard, 32 patients were treated with hemithyroidectomy alone, and total thyroidectomy was performed in 56 patients. And we had post-op RAI in 34 patients. The majority were in total thyroidectomies, and that included the patients with 5 patients with low volume metastatic disease. Next, please. And the results, no local or regional or distant recurrence or disease-related mortality in the entire cohort, including these real patients of interest, hemithyroidectomy without, or total thyroidectomy without RAI. So the authors conclude that there's an excellent outcome, and this is in a well-culled group of large intrathyroid, low-risk thyroid carcinomas. Next, please. So the limitations, as we heard, retrospective nature, the small number of patients of interest. So it's really, the end goal is to get more patients who have just been treated with hemithyroidectomy and no RAI. Now, BIN has mentioned the fact that the entire capsule was not sampled in a significant portion, as is now a current practice, but was not, in the earlier patients. Although this is cited as a limitation, the fact that these patients all had an excellent outcome really argues against this limitation having any impact in this group. So in my opinion, a limitation is basically the ultra-conservative nature defining the patients of interest. So I would love to see in subsequent studies a comparison group of large, well-differentiated ETE, large, well-differentiated thyroid cancers with minor ETE. As we've heard in many of these TIRO's lectures, minor ETE seems to be on the launching pad for being removed as a risk feature. Currently, when we see anything with minor ETE, because I like to give ATA state ROR in my path reports, any minor ETE will bump something up to intermediate risk, but it's a very low bump. And most surgeons I have heard will not do a completion based only on minor ETE. So to me, that's a very big area of interest. And as a prospective study or a retrospective modern study, and we'll be discussing that. What I would like to see in next studies is dropping the capsule criteria and perhaps any, minimal vascular invasion, one vessel, two vessels. We know that the cut point of 4 and more is very important. If we creep up on these risk features, are there any other risk features, like perhaps one vessel involved, that really kind of remove us? We could still think of these tumors as low risk. And I think that is my last slide. Yes. Congratulations, Ben.
Thank you.
Thank you very much, Margie. That was wonderful discussion. You made it very succinct and goal-oriented, so thank you very much. We've got ample time to discuss these two presentations, and I think getting the input from both these pathologists as a surgeon is very crucial. There is a question in the chat box. I'm going to ask that first and then bring up the whole discussion. And the question is, which patients with minimally invasive follicular carcinoma will require radioactive iodine? And I think as a clinician, maybe I'll start the answer and then see what our pathologists have to add. To be frank and honest, the whole idea of dividing follicular carcinoma into minimally invasive and widely invasive is to direct the clinician who should require radioactive iodine. The widely invasive, major vascular invasion, major capsular invasion, major extrathyroidal extension, yes, they will be benefited with radioactive iodine. The minimally invasive, only capsular invasion, no vascular invasion, I don't think will benefit them in any way by giving a radioactive iodine or doing a completion thyroidectomy. I think this is a major paradigm shift in the management of thyroid cancer. And that's why this paper is very important, because there will be a certain group of patients which are a little more aggressive. And what do we do about them? And I think the BIN's study is very important, that even in that group of patients which are larger, the outcome is the same. And I think this is a message that goes to everybody, that these patients will do very well. Bin and Margie, any comments on this?
Bin,
I totally agree, Dr. Shaha. So what you mentioned, usually what we select for patients for RAI, such as extensive angial invasion, widely invasive disease, in the context of minimally invasive thyroid carcinoma, we choose large size because that's actually per guideline that need to be considered for post-op RAI. But in our center, I think we try to downscaling the therapy a lot. That's why in our group, about 60%, 65% doesn't receive RAI, and they do well. So that's a more controversial topic. And based on our study, we are hoping that this group of patients actually does not need RAI in the future. Rather, it's just a close follow-up with a conservative surgery would be sufficient for the patient.
Thank you, Bin. Margie?
Yeah. So I start by teaching my fellows and my residents, the first decision point in terms of minimally invasive versus invasive is you read the gross examination. And it's a good starting point, but there are cases where it's not so clear. So there are times where the gross examination will say that there's a well-demarcated tumor, encapsulated tumor, but there's so much capsular invasion and there's so much invasion into the gland that even though it is described as a single dominant encapsulated nodule, I will bump it over into the widely invasive just because it doesn't make sense to me. So there's a gray area there. And I would say that the way I deal with that gray area is I no longer call it minimally invasive. But the next person, by just going by the guidelines, might call it minimally invasive. So I would say that real minimally invasive with no vascular invasion obviously doesn't need radioactive iodine. The question is, what happens when you have less than extensive vascular invasion, right? Less than less than 4. Well, you know, there's a lot of variation in what people call vascular invasion. And Ronnie runs this excellent consensus conference every Tuesday at Memorial. And we get to see what people are, you know, when people are worried about vascular invasion. So we get to see the diversity of what is considered vascular invasion. So normally, if I find a textbook image, so my criteria is, would I put a picture of this in a book? You know, if I could put a picture of this in a book for the first focus of vascular invasion, I'm going to call it. Then when it comes to subsequent, you know, vascular invasion, I'll say, well, it's not quite textbook, but I'm going to call it. So my criteria kind of drop a little bit once I have my first textbook example in a tumor. And you know, one would think, well, if you find 3, you're going to find 5 if you only look harder, but sometimes you don't. So I would say that there's a borderline, a gray line between, you know, let's say 3 and 4, 3 and 5, where it's not clear whether or not that patient should receive radioactive iodine. I think that to be conservative and to probably patients should receive at this point radioactive iodine if they have more than one vessel involved. One vessel involved, I don't know.
Thank you very
I'd
much,
like
Margie.
Yeah.
You know, the Memorial wrote a paper about 10 years back and used 4 vessel as a cutoff. The Japanese Ito group have used 2 vessel as a cutoff. So I think we're probably still on the learning curve in this. What remains unclear, and I think we as clinicians need to realize, when you say 2 vessel vascular invasion, there may be 3 or 4 that you have not been able to identify, or you have not looked at the entire tumor 360 degree. So there is a question in follow-up from our director, Mark Arkan, and I think there's a very intriguing question. What do we do when the pathology is so critical and we are in a community hospital, we don't have Margie or Bin in our institution or Rani Hussain? Should we send the slides to you for a review? And will that help us, or should we be content with our own pathologist? Margie, you are the senior person here, so I'm going to focus the question to you.
Well, I would, of course, say yes. I would say that the yield of change would be low, but worth the effort. Certainly, we have all seen cases in the past that have not been correctly diagnosed, and we deal with the fallout of those incorrect diagnoses, and they're seared in our brain. So I can't tell you what the rate of significant change would be. Maybe it's only 1 in 100, but it's certainly, in my opinion, it's certainly worth the effort.
Bin,
I totally
before
agree.
you answer, I'm going to ask an addendum question.
Yes.
When you get the slides from outside, you don't get all the slides. You just get a selected group of slides. So can you use that to make a final decision and say, this is the final pathology? Or would you addendum that by saying, these are the slides that we received? There may be much more truth in this whole pathology.
When we receive an outside case, I think the chance is half-half. So most of the time, half of the time they give us all the signs, so we do evaluate what they have, and the other half of the time we receive representative signs. When we really think our pathology report impact the clinical outcome or clinical management, we actually do have a choice to request additional material to be sent to us. So we can request all the size. So, for example, if we want to evaluate the extent of angial invasion, we usually request all the sites to be sent to us. We also can additionally ask outside the hospital to submit a capsule entirely, for example, and waiting for the additional sites to finalize our report. So we do have occasionally, we only review representative size, but if the diagnosis is straightforward, if you already have extensive angial invasion, then we issue a report based on representative size only and state so in our report. but we do from time to time request more material to be sent to us for more accurate diagnosis. And I totally agree with Dr. Brandwein that even the rate of change is low, even it's 1 in 100, when it really changed the clinical management, it's probably safer to send it for pathology review so that important parameters such as angial invasion is not missed.
Thank you very much, Bin. Maybe you can expand a little bit on what is the difference between lymphatic invasion and vascular invasion. There was a time when one pathologist could not distinguish one from the other, but Rani tells me now that he can categorically tell this is a vascular invasion. Bin, you are a part of that group. Can you expand on that a little bit?
Yeah, so the old pathology guideline being the College of American Pathology guideline, they lumped the lymphatic invasion and angial invasion together for thyroid carcinoma. That was like a decade ago. And then since the last few edition of the pathology guideline, we have to separate lymphatic invasion and angial invasion, mostly because lymphatic invasion doesn't show evidence to impact prognosis, while angial invasion, especially extensive angial invasion, do have a higher risk of distant metastasis and impact survival. So there's no good histological way based on H&E size to separate those two apart. So these days, we recently performed a study using immunohistochemistry of CD31 and D240. Well, D240 only selectively labeled lymphatic, but not angial, not vascular channel. So we use immunohistochemistry to tell them apart. So the short answer is yes, we are able to separate them apart accurately, but using immunohistochemistry, not on H&E alone.
Thank you very much. That is very, very helpful. And I think, again, going back to what you have done is try to analyze the pathology more critically and help us to make critical clinical decisions. I have one question for both of you. Occasionally, the final pathology report will say tall cell variety or solid variety. Where do we go with this? Margie, let's start with you.
Well, thank you for that question. Ronnie and I and a small group of other pathologists have been working on tall cell. I've been working on this for years with Scott Doyle, who is a computer vision scientist at UB, and we're working on building a classifier to recognize tall cell. This is one of my sort of pet hang-ups in that if you look at the definition of tall cell, it looks like we're dealing with a mathematical problem. I mean, if we could only measure all the cells, and then we can come up with a very accurate definition. But in fact, this is not a real mathematical cell geometry problem. What I believe personally is that it's pattern recognition. We all agree that tall cell impacts outcome, and even among stakeholders, we can't so far come up with good agreement on just visually, agreeing between areas, annotating areas that we think are tall cell. So we are working on this. We have another experiment that's coming, but we have developed a classifier so far that's based on Mount Sinai definition of tall cell. The ultimate end goal is to develop a AI classifier that is based on outcome, not based on my opinion or Ronnie's opinion or Zhu's opinion, but can be a reproducible AI classifier that has been validated based on outcome.
So what should we do today when your report comes solid or a tall cell? Should I go back and take out the other side?
Okay, wow.
Benefiting the patient?
What a question. So solid is different, okay? Solid is a different question.
Okay.
And if it's tall cell, you might want to ask, what is the cut point? The cut point for the WHO is now 30% or more. But as WHO says, and as I can confirm, there is no data There is no robust data that compares a 10% cut point versus a 20%, a 30% cut point. The mind would think, well, if it's 50% tall cells, it's worse than a 30% tall cell, just like the mind would think if it's a 10-centimeter tumor, it's worse than a 3-centimeter tumor, but not so. The data doesn't support that. So what I can tell you is there are two multivariate analyses. There are two studies that include multivariate analyses. I'm embarrassed now because I don't remember the name of the first study, and ours was the second study. But if you look in our manuscript, we have a table of all the tall cell studies that include multivariate analysis. There are two studies that support a 10% cut point. One of them is ours, and then there are a number of studies that support a 30% cut point, but it's really a handful. We're talking about 6, as of, let's say, last year, 6 studies in the literature on tall cell that include multivariate analysis. So this is a topic that I continue to grind away at. And, it may be my last stand before I die, but this is what I want to solve.
That's not going to happen for a long time.
God willing. It may be my last stand.
One more question to both of you. Occasionally, when the biopsy report is Bethesda 3-4, we get a molecular analysis, and that is BRAF. Should that change today, our decision making? And Margie, you are on the WHO committee. Will the BRAF be added to the staging system or the definition of thyroid cancer?
So now that BRAF immunohistochemistry is available, I think there's going to be a further explosion in terms of what the meaning of BRAF is on a practical basis. And so right now in the ATA-ROR that we work from, BRAF does impact outcome. You can only really see it in like large meta-analyses. So in my opinion, BRAF is not the whole story. And I think that time will tell. And I'm interested to hear what Bin has to say about this.
Bin?
Yeah, I once again agree. I think BRAF, based on the TCGA data, it does not predict outcome. Only like occasional meta-analysis showed BRAF impact survival, recurrence-free survival. So in my opinion, BRAF V600E just means it is a classic or tall cell subtype. And the actual risk stratification and determining of the procedure, either it's total or lobectomy, still depends on other risk factor. By itself, it shouldn't impact the surgical operation extent.
Thank you very much. I think that is very, very helpful to us.
Yeah.
I'm going to ask one more question from Mark Arkan. Margie, will we be discussing this same thing 5 or 10 years from today about the capsular invasion, the vascular invasion, or do you think that you will be able to resolve this and give us the gospel truth?
That's a great question. Yes. I believe 10 years from now, it'll be a different paradigm, and it will be more molecular based, although just in terms of classification. So, everything comes, full circle. Follicular patterned carcinomas were a thing, let's say in the 70s, in the 60s, which included a lot of, follicular variant PTCs, right? And follicular carcinomas. And I think we're going to go back to full circle in the future with an initial stratification based on, is it a RAS pattern, a BRAF pattern, plus, microRNAs, plus perhaps other signatures. And that's going to be sort of a main stratifier. And then we add on these other variables. One of the things that never ceases to fascinate me is the difference between prognosticating thyroid cancer and, squamous cell carcinoma of the head and neck and salivary cancers. They seem so easy, relatively easy to stratify. But thyroid cancers in general are so multifactorial. It's like an order of magnitude greater than all of the other cancers that we deal with. And so, it always fascinated me that a tumor that presents with distant metastasis, okay, it declares itself, as we say, at initial presentation. But if you just gave me the slides of that tumor, I would not be able to predict that it presented with metastases. So to me, that's and certainly aggressive metastases. So that's a fascinating, inherently fascinating aspect of thyroid cancer.
Thank you very much. I think the bottom line is you need an excellent pathologist to work with. And we are extremely fortunate in a tertiary care center having the pathologist. And as I mentioned before, more importantly, that we can reach out to them anytime and ask the question. And, sometimes I feel embarrassed to ask questions or challenge them. But I think as time goes, I learn that they are most welcoming for our questions because they know I'm going to take care of the patient. And I think that is very helpful. I just have one addendum to this. Been described mainly 4-centimeter thyroid tumors. By necessity, these tumors are going to come out of the thyroid gland. The thickness of the thyroid is barely centimeter or centimeter and a half. So it is not uncommon that we find minor extrathyroidal extension in these tumors, which has kind of defined in the staging system as no prognostic indicator. However, as a clinician, as a surgeon, what I do in the operating room is I take the sternothyroid muscle, which is wrapping on the surface of the thyroid. So when the final pathology report comes that there is a minor perithyroidal soft tissue invasion or perithyroidal adipose tissue invasion, I feel very confident that I have done a good surgical procedure. And I take sternothyroid muscle, which is essentially a vestigial muscle. It has no function. So that's my approach in the operating room. Margie, just one question about the positive margin. Just expand in 30 seconds. What do you mean by positive margins? And when you write that, there is the whole bell starts ringing and the patient starts saying, wow, my tumor has positive margin. What do you think?
Oh my God, why did you save this for the last 30 seconds? I wanted to ask you, Ben, and not deflecting your question, what do you think when you see no ETE, no microscopic ETE, but positive margins? Does that make any sense to you? I always ask that question. So, I have my own definition of positive margin, which is really, it's cut through, you see a cautery, you see all of the signs. And yet in many instances, the surgeons don't seem to care. And I would like to have an in-depth, discussion on that with my surgeons, with the thyroid group, because I need to educate myself. There's no such thing as there's no interest in close margins in thyroid. Fine, I got that, because I'm so intimately involved on a daily basis with squamous cell carcinoma and margins, it kind of blows my mind that margins in thyroid cancer are just less significant.
Right. And we are very happy here that many times we get a call from our pathologists before they sign out, what did you see at the time of surgery? And I think, the most important thing in thyroid surgery is what the surgeon did in the operating room, how he felt at the end of the operation. Was he happy with the resection margins or was he not happy? I think that's the most critical thing. And I think that brings us close to an end of the hour. Margie and Ben, you did a fantastic job, excellent presentation, and outstanding work that you have been doing. I would appeal the audience to attend to the next week's TIRO symposium on Friday morning at 8 o'clock. Be sure to tune in to Voices of Wisdom, our podcast dedicated to medical professionals in thyroid cancer treatment. Each month, we explore experts around the world for their groundbreaking research. Catch new episodes of Thyroid Podcast every third Tuesday of the month and stay ahead in the field of thyroidology. It is available on the Apple Podcasts or Spotify. And I am very proud to inform you that these voices of wisdom are moderated by one of my close friends, Dr. Janice Pasica, who is a world-renowned thyroid surgeon and a major contributor in the field of thyroid podcasts. So stay tuned and please watch out for Janice Pasica. We'll see you next Friday morning. Thank you very much.
Thank you, Ashok. Thank you so much.